Hey everyone, welcome back to my channel. So in this video I'm gonna give you a really simple basic understanding of the EKG and how to read every part of it. So let's get started. Alright, so the EKG is a sum up of all the action potentials taking place inside cardiac myocytes and cardiac cells, because when electrical activity happens in the heart, we have positively charged ions moving to one end. So it's like a battery that we're looking at the waves or its voltage. Alright, so when the action potential starts out in the SA node of the heart, causing atrial depolarization, this comes as a trace of the P wave. After that, there is some sort of delay here at the AV node before we reach the ventricles, and this is recorded as the PR interval. And then we reach the ventricles and action potential spreads there, recording the QRS. And then when it's complete and before repolarization, nothing happens, so this is the ST segment, and then repolarization starts, recording the T wave. Now the PR interval, guys, is everything taking place from the SA node all the way until the atria are depolarized, and the QT interval represents ventricular action potential all the way from depolarization to repolarization. So the first thing I want you guys to look at when reading an EKG is the rhythm. The rhythm tells you which node is pacing the heart, which focus is pacing the heart. Is the heart running at the pace of the SA node, or is it something else? So this is the first thing you should look at on the EKG. If the SA node is pacing the heart, which is the normal, then every QRS will be preceded by a P wave. It means that ventricular action potential is a result of SA nodal depolarization. So a normal sinus rhythm means it's the sinus, means it's normal. The SA node is pacing the heart, means that whatever is going on in the ventricles is paced by the SA node. So every QRS is preceded by a P wave. It means that whatever electrical activity started in the atrial SA node has reached the ventricles, causing depolarization. Now, if there is any other ectopic focus other than the SA node, this is an abnormal rhythm. And in this case, not every QRS complex will be preceded by a P wave. You can see here that we have a QRS preceded by a P wave. This is normal sinus. QRS preceded by P wave. This is normal sinus. However, here, this QRS complex is not preceded by a P wave. So this is a premature contraction, not resulting from the SA node. There is no P wave here. And that's a supraventricular rhythm. Now here again, this is a QRS preceded by P wave, QRS preceded by P wave, so this is resulting from sinus node. However, you can see here that this QRS complex is not preceded by a P wave. This is abnormal, and it's coming from a different focus. In this case, it's a ventricular focus. Now, how did I know that this is a supraventricular focus and this is a ventricular focus? If the QRS is narrow, it means it flowed through the conduction system of the heart, which is quick, then that's supraventricular. If it's wide QRS, it took time to flow through the cardiac myocytes, not the conventional conduction system, then it's ventricular. So this would be abnormal rhythm. The first thing you should look at in the EKG is rhythm. Now, if the rhythm could be atrial or ventricular. If it's atrial, from one focus could cause an atrial flutter, or from multiple foci around the pulmonary veins causes atrial fibrillation. In either case, guys, a QRS will not be preceded by P wave. This is what flutter looks like, and this is what fibrillation looks like. In either case, it's not the SA node that's based in the heart. It's another focus above the ventricle, supraventricular. and therefore the heart rate will be irregular. So here is an example of findings of atrial fibrillation. You can see here that the heart rate is irregular and we cannot see P waves. The second thing you should look at in any EKG, guys, is the rate. What's the heart rate? The heart rate would very simply be calculated through dividing 300 by the number of big squares. So here, for example, between each R 1, 2, 3, 4, so 300 over 4, I would say the rate here is 75 beats per minute. Now, the sympathetic nervous system acts on the SA node to stimulate faster pulse. So it's going to be higher with atropine or adrenaline or theophylline. And the opposite is true for the vagus nerve, or parasympathetic stimulation causes a slower SA node and AV node as well. An example will be vagal stimulation, for example Valsalva, and that's how we abort supraventricular rhythms. Or we can use beta blockers, calcium channel blockers, adenosine, and these are second line after vagal maneuvers. Now the same goes for the AV node, so the SA node and the AV node, and that's why vagal stimulation may delay AV nodal conduction to the ventricle. So let's imagine if the SA node, which is the normal sinus rhythm, is blocked or not working. It means I will have no P waves. When there is time for a P wave to come and stimulate the heart, it's not coming, as you can see here. So here PQRS, PQRS, PQRS means the SA node is placed in the heart, but here no P means the SA node is blocked. So this is a normal sinus rhythm with no block. When you do excessive vagal nerve stimulation, it can block the SA node. So this is called sinus arrest. It means that because the SA node is blocked, which is the normal rhythm is 80, another node is taking over. They take turns. When the normal sinus is not placed in the heart, another node takes over the responsibility and starts pacing the heart, but it's obviously slower, and that will be the AV node. This is called junctional rhythm, and it will be around 45. You can see here the big number of big squares are a lot, indicating slow heart rate. Now when even this one fails, the AV node fails as well, junctional escape rhythm, we need something else to pace the heart, otherwise the heart will stop. In this case it will be the ventricles, but obviously this is gonna cause a wide QRS because it's not flowing through the normal conduction pathway, and it's obviously much slower at 40 beats per minute. So after you look at rhythm and rate, number 3 is axis. What does axis mean, guys? When the action potential flows in this way, as you can see, like a battery, positive waves moving this way, it will draw a positive wave on the EKG trace. If it moves away, it will draw a negative wave. So positive ions moving this way draws a positive wave. Positive ions moving against this way will draw a negative wave. You can see here that most of the heart, guys, is directed this way, right? So most of the ions or positive waves will be in this direction, what we call a vector, and that's called the cardiac axis. So if I have an eye here, I'm looking at the heart in this direction, I should see positive waves, right? So this is the site of lead 1, and this is the site of lead 2. In both cases, the cardiac activity is going towards them, so both have to be positive. And that's a normal cardiac axis. Now, because lead AVR here on the right side is away or against the direction of ion flow, then it will record as a negative wave. So this is the normal axis. As you can see here, positive means I'm going this way, draws a positive wave. I'm going that way, I'm drawing a negative wave. So we have a 12 lead EKG, 6 on the chest, and limb leads. This is lead 1. I'm viewing the heart from this direction. Lead 2 views the heart from that direction. Lead 3 views the heart from this direction, and so on and so forth. It's as if I have a camera and taking pictures of the heart from different directions. If I am looking here at this point, or let's say at this point, I am viewing the heart from the direction where ions are going this way, so it's going to be positive. If I'm looking here, I'm viewing the heart upside down, where positive waves are going away from me, and so we will record a negative wave. The normal cardiac axis is in this region, guys, where most positive waves are going this way. It means that lead 1 and lead AVF1 and AVF will be positive. This is what you should look at in the EKG when reading it. Rather, if the axis of the heart is deviated to the left, as you can see here, if it's deviated to the left, it means that lead 1 will still remain positive, but here, because I'm away from lead AVF, it's gonna be negative. You can see here negative 90 instead of positive 90, because I'm moving to the left. Now, if I'm moving more to the right, I'm moving away from lead 1. I'm moving away from lead 1 like this towards lead AVF, and so lead 1 will be negative, AVF will be positive. So normal cardiac axis, positive lead 1, positive AVF. Left axis deviation, positive lead 1, negative AVF. Right axis deviation, negative lead 1, positive AVF. The fourth thing you should look at, guys, when reading EKGs are the waves. So we discussed first rhythm, rate, axis, and then waves. It's important to go in sequence so you don't forget anything and miss pathology. Now, this is the EKG tracing. Every wave has a certain amplitude and duration that it should not exceed or be less than. Now, every small square on the x-axis represents 0.04 seconds, and every small square on the y-axis represents 0.1 millivolts amplitude. Alright, so one big square is 0.2 seconds and 0.5 millivolts. We will discuss every duration and amplitude of each of these waves and intervals. Now, let's start with the P wave, duration and amplitude. The normal P wave, guys, representing atrial depolarization, means that the SA node is spacing the heart. Without the SA node, we don't have a P wave. The normal P wave duration should not exceed 0.12 seconds, which would be 3 small boxes. And the normal P wave amplitude, representing depolarization of the right and left atrium together, should not exceed 2.5 small squares, which is 0.25 millivolts. Now, a high P wave amplitude, which is 0.25 millivolts or more than 2.5 small squares, is called P pulmonale, indicating right atrial hypertrophy. A long duration of the P wave, taking more than 3 small squares, more than 0.12 seconds, is called P mitrale, and it's caused by left atrial hypertrophy. Next will be the PR interval. This is the time, guys, where impulse is delayed at the AV node until the ventricles fill before contracting. And so this is very important. If I have a short PR, ventricles will not have time to contract. Long PR means I'm not delivering an impulse to the ventricles well at a timely manner, and therefore I'm going to have a very slow ventricular rate and low cardiac output. The normal PR interval duration, guys, should be 0.12 to 0.2. Meaning that it should be around 3 small squares. Now, a short PR is one that is less than 3 small squares, and that means there is an accessory pathway other than the AV node through which conduction is going faster than it would in the AV node, so there is no delay. And this happens, guys, in something called WPW, or Wolff-Parkinson-White. You can see here that the SA node is escaping the AV node and instead going through a faster pathway, so have a very short PR. Now, on the other hand, the PR interval could be very long, more than 1 big square, which is more than 0.2 seconds. And that means there is AV nodal delay. Now, the AV node may be just delayed, and this is called first degree heart block, or may be completely non-functioning, and this will result in dropped beats. Up to complete AV block means no impulse is reaching the ventricles from the SA node. So first degree AV block, as you can see here, guys, the PQ interval, or the PR interval, is just longer than usual. It's longer than it should, more than 3 small squares. In second degree AV block, however, there is 2 types. There is one where the PR interval is gradually increasing. You can see here that it's normal, and then it's getting longer and longer and longer until we have a dropped beat. Means a P wave with no conduction at all, means no QRS, no ventricular depolarization, that the SA nodal wave did not make it to the ventricles because the AV node is not functioning. Missed QRS. Another example of second degree AV block is fixed PR interval, not progressively increasing, but missing QRS every time. So here we have every 3 beats, we have 1 missing QRS. Every 3 beats, 1 missing QRS. Third degree AV block, on the other hand, guys, or complete AV block, means there is no QRS whatsoever. You can see here we have SA node is firing, SA node is firing, SA node is firing, but nothing is reaching the ventricles, so there is no QRS. In this case, another focus, guys, has to start out and fire from under the AV nodal block in order to reach the ventricles. Otherwise, the ventricles will not contract and this person will die. So another focus has to start here, for example, bypassing the AV node in order to pace the ventricles. In this case, there is something called an escape rhythm. Distal to the AV nodal block, a junctional escape rhythm at this junction is starting to conduct to the ventricles, and another ectopic focus, and you can see here that we have a narrow QRS. However, this, guys, is not considered normal rhythm. This is not normal sinus rhythm because the ventricular depolarization is not because of the SA node. The SA node is firing on its own, and the junctional rhythm is firing on its own to stimulate the ventricles with no communication. So there is complete dissociation between the P waves representing the sinus rhythm and the QRS that result from the junctional rhythm. For this reason, not every QRS is preceded by a P wave, and that's, guys, what I mean by the fact that it's not a normal sinus. A normal sinus means every QRS is preceded by P wave. This is not the case here. Now, let's say the escape rhythm is not junctional, rather it started out in the ventricles, means it will not flow through the conventional conduction pathway. It will be much slower, and therefore the QRS will be wider. Next up, guys, I'm gonna talk about the QRS complex, amplitude and duration. The normal QRS has to be narrow, indicating it's fast, of a small duration, less than 0.1 seconds, because I'm flowing through the normal conduction system, and meaning that it has to be no more than 3 small squares, because I'm going through the fast conduction Purkinje fibers. So a narrow QRS means that the focus, regardless what it is, whether SA node or atrial or junctional, originated above the conduction systems, which is supraventricular, causing narrow QRS because I'm flowing through a fast pathway. If you see a wide QRS, long duration, you know that the focus is probably ventricular and it's not flowing through the normal conduction pathway. Next up, guys, would be the Q wave. The Q wave, guys, representing septal depolarization, is very important to look at when checking for myocardial infarction. A high amplitude of the Q wave, if it's very deep or very wide, indicates MI. Now, the R wave amplitude, guys, is progressively increasing from V1 to V6 across the heart. And the S wave progressively decreases. You can see here, this is a small R, deep S, but then the R keeps rising and S keeps falling. R rises, S falls, until we have a very tall R wave near the left ventricle. Now, R wave amplitude, guys, on different regions of the heart represents chamber enlargement. The bigger the heart muscle, the more the cardiomyocytes, the higher the amplitude of the R wave. So in the leads near the left ventricle, like the V5 and V6, a very tall R wave indicates left ventricular hypertrophy. And in the leads near the right ventricle, V1 and V2, a very tall R wave indicates right ventricular hypertrophy. Now, guys, to the bundle branches. In the conduction system of the heart, to the right side, we have a right bundle branch to reach the right ventricle, and to the left side, we have a left bundle branch to reach the left ventricle. Now, if the right bundle branch is blocked, then the depolarization will have to reach the left ventricle first and then go to the right ventricle. So it's going to be delayed at the right ventricle and vice versa. So here, guys, would be an example of a right bundle branch block. Because conduction here cannot reach the right side of the heart, it's gonna reach the left side first, and from the left side would then start reaching the right ventricle. Now, as a result of this leeway, the waves are kind of abnormal. So the V1 starts showing this sign, RSR, because the R here represents when the depolarization was going this way, but then it stopped, and then it went to the other direction, and that's why it's causing an S wave, and then back again at number 3 towards the right ventricle, which drew an R again, so RSR. And the V6 shows a QRS, which is normal. On the other hand, with left bundle branch block, the conduction was going this way, but instead of going to the left side, it's blocked, so it has to go through the right side first and from there to the left side. And therefore, it's going to be kind of delayed. For this reason, in V6 representing the left ventricle, the wave appears wide like this, wide R. Next up, I'm going to talk about the ST segment. The ST segment, guys, is kind of a break before repolarization of the ventricles. Now, an ST segment has to be flat, ST isoelectric. If it's elevated, indicates there is MI. If it's depressed, indicates myocardial ischemia. So here's an MI, myocardial infarction, guys. The area where there is dead cells means there is no repolarization whatsoever, and here it's going to show ST elevation. The area where there is ischemia will show ST depression. Now, how do you figure out which part of the heart is infarcted? And that's based on the EKG chest leads, guys. We already mentioned before that V1 and V2 represents the anterior and septal wall, anteroseptal, towards the right ventricle. V3, V4, V5, V6 representing the left ventricle, right? And the limb leads as well. These are the limb leads. So if I'm talking here about the septum, here's the infarction, that's V1, V2. If I'm talking inferior wall myocardial infarction, I'm looking at them through the limb leads, 2, 3, and AVF, called inferior leads. So leads, and ST change in leads 2, 3, and AVF indicates inferior wall infarction. ST changes in leads V1 and V2 indicates septal wall infarction. ST changes in leads V3 and V4 indicates anterior wall infarction, and so on and so forth. And that's how we view the heart from different angles. So here's an example, guys. If you look at leads 2, 3, and AVF, you find any ST changes, you know it's the inferior wall of the heart that's affected. V5 and V6, you know it's the lateral wall of the heart that's affected. Next up, guys, I'm going to talk about the T wave, duration, and amplitude. The T wave represents ventricular repolarization, which is a result of potassium efflux. Now, if this is kind of slow because of hypokalemia, then this is gonna, or it's not of high amplitude, it's gonna cause a flat T wave. If it's a very high amplitude because there's a lot of potassium due to hyperkalemia, it's gonna be a tall T wave. If repolarization is reversed or affected because of ischemia, the T wave will appear inverted. Now, let's sum up the entire action potential called the QT interval, representing ventricular action potential, depolarization and repolarization. The QT interval, guys, should not exceed half the duration of the RR interval. So here's the RR interval. For example, let's say we have 4 big squares. The QT interval should be no more than half the RR, so no more than 2 big squares. That's how you read it on the EKG. Because if it's longer than this, it means I'm giving a chance for new ectopic foci to appear in the ventricles and a very dangerous type of arrhythmia called torsade de pointe or polymorphic ventricular tachycardia. And this could be a side effect of drugs like antidepressants, antipsychotics, or due to hypocalcemia. That's something we should look at, the QT interval. I hope this video helped, guys. Let me know what you think.